Hello everyone, welcome to my YouTube channel Physioflix. Sit back and enjoy physiology. So today we would be discussing about a very important and high yield topic which is the obstructive and the restrictive lung diseases. This topic is very frequently tested in boards step 1 exam and various university exams. So first of all, we would be discussing about the pathophysiology and the general discussion about obstructive diseases and restrictive diseases. Then we would be moving towards categorizing various disorders and pathologies in between these two diseases. Then we would be discussing about the lung volumes and spirometry results in restrictive disorders and obstructive disorders. And finally, we would be concluding our discussion in the fact that how step 1 tests your knowledge about obstructive and restrictive lung diseases. So first of all, we would be having a very general discussion, a very uh, general point of view about what obstructive lung diseases are and what restrictive lung diseases are. So obstructive lung diseases are the diseases in which the patient cannot get the air out of their lungs. So you would also find authors who write obstructive lung diseases as the air gets trapped into the alveoli of the patient. So we say that there is a premature airway closure and the patient cannot push the air out from the alveoli into the back into the atmosphere. Whereas the restrictive lung diseases are generally explained as the kind of diseases in which the air cannot get into the lungs. On the contrary, we just discussed that in the obstructive diseases, you cannot get air out of your lungs. And in restrictive diseases, we say that the patient cannot get air into the lungs. So there is poor oxygenation because the patient cannot get air into the lungs, which is very obvious. So how would the patient present and how would uh, be the signs and symptoms of the patient? So the patient presents with short and shallow breaths because the patient cannot uh, get the air into its lungs. So we also define restrictive lung diseases as that there is a restriction in the lung compliance. So what does that mean? That the patient is having a disorder that is a restrictive disorder in which the patient cannot get air into the lungs because of reduction in lung compliance, which means that there is a reduction in the expansion and contraction of the lungs itself. So I think I make sense over here that the patient is having a reduction in the lung compliance and will present with short and shallow breaths. So, what are the pathologies which are classified into the obstructive diseases and the restrictive diseases that are the chronic obstructive pulmonary disease, asthma, etc.? We would be discussing the others too. And then in the restrictive lung diseases, the interstitial lung diseases, scoliosis, kyphosis, etc. So this was a very general and a brief discussion and introduction of the two diseases. Now we would be looking at the lung volumes which are changing due to these kind of diseases. So first of all, we would be discussing about three very important lung volumes, which is first of all the residual volume. So for those who do not know what residual volume is, residual volume is the amount of air in your lungs which you cannot push out, uh, even if you have a forceful expiration. So I understand this concept as you need some air in your lungs to keep it expanded and to prevent your alveoli from collapsing, and that is the residual volume is that amount of air. So if I look at this lung volume graph, then you would see this is the residual volume. This is the amount of air which the patient cannot get out even if the patient has a forceful expiration. Now let us discuss what happens to the residual volume in the obstructive and the restrictive lung diseases. As we have discussed earlier, that the obstructive lung diseases, there is an issue with the patient to get the air out of the lungs. So the patient already has an issue in getting the air out of the lungs, and here the residual volume would increase. I think it makes sense because there is an issue with getting the air out of the lungs, and if there is some residual air already present, you would not be able to get the extra air out, so the residual volume will eventually increase. So I would just recap this thing that residual volume is the amount of air that is left in the lungs even if the patient has a forceful expiration, and this residual volume increases in the obstructive lung diseases. So in the restrictive lung diseases, it makes sense that the residual volume decreases because the patient, as we had discussed earlier, that there is a decrease in the lung compliance and patient cannot get air into the lungs. So next is the functional residual capacity. Now, what is functional residual capacity? The functional residual capacity is the amount of air that remains in the lungs whenever the patient is having normal breaths. That is the tidal volume. Now, for those who do not understand the concept of lung volumes, I would just briefly explain a bit about it. That if a patient is expiring and inspiring at a normal rate, at a very eased rate, that I must say, the patient is inspiring and expiring a tidal volume. And if there is a forceful inspiration and a forceful expiration, then the forceful inspiration is the inspiratory reserve volume, and the expiration is expiratory reserve volume, that the patient can inspire this much air and the patient has the capacity to expire this much air. So the functional residual capacity would be the air when the patient is breathing on the rate of of the tidal volume, that the patient is inspiring the tidal volume and expiring the tidal volume of air, and this amount of air, which is the residual functional residual capacity, remains in the lungs of the patient. So if I would try to explain it in the form of a cartoon, that this is a patient and the patient is breathing at a normal rate. This is normal patient, a normal patient, and the lungs have air inside them. And what is the amount of air at this point of time? That amount of air is the FRC. I hope I have succeeded in explaining this in a simple way. So now what happens to the FRC? As the FRC itself includes the residual volume and the expiratory reserve volume. So what would happen to the FRC in obstructive lung diseases? The FRC would be raised and the FRC would be decreased in the restrictive lung diseases. Whereas the total lung capacity, as the FRC increases, as the residual volume increases, the total lung capacity increases in the obstructive diseases and decreases in the restrictive diseases. So, without explaining much about these pathologies, the obstructive lung diseases include the asthma, bronchitis, chronic bronchitis, and emphysema. So, these are the diseases that are categorized as the obstructive lung diseases, and sarcoidosis, pulmonary idiopathic fibrosis, pulmonary tuberculosis, and a pathology related to the musculoskeletal system, myasthenia gravis, also categorizes as the restrictive lung diseases. So, we have discussed a bit of basic stuff about obstructive and restrictive lung diseases in our prior discussion. Now, we would be moving towards the spirometer graphs relating to the patients of restrictive and obstructive lung diseases. So, first of all, we need to understand two concepts. Now, what are the two concepts? Very easy and basic concepts, but people make a fuss out of it. The concepts are of FEV1 and FVC. So, what is FEV1 and what is FVC? So, FEV1 is basically forced expiratory volume in 1 second. Now, forced expiratory volume in 1 second means that the amount of air a person can forcefully exhale from their lungs in 1 second. Like if this is a patient and the patient is performing a spirometry procedure. So if a patient forcefully exhales air from their lungs in just a second, this is FEV1. Now, what is FVC? That now this patient, what the patient does is that a patient makes a deep breath, the deepest possible breath, and then forcefully exhales that breath. Like this is the patient, and the patient takes the breath in, and then the patient exhales with with in a full forceful expiration. Now, what would happen in the graph of the spirometry? That the patient inhaled some amount of air and the patient exhaled some amount of air. So this is what we call as the FVC. That FVC is basically defined as the maximum amount of air a person can forcefully exhale after measuring the after taking the deepest possible breath. So I hope I just make sense over here. Now, talking about the graphs here, which are the FVC and FEV1 graphs. Now, if we look at FEV1 for a second, now what was FEV1? FEV1 was forced expiratory volume in 1 second. Now, if you consider this person as normal and this red graph as a spirometer graph for a normal person, then you would see that FEV1 has a certain value represented here. All right. Now, if the patient is suffering with a restrictive lung disease, which are mentioned over here, any of among these diseases, the patient would have a lesser FEV1. But if the patient is suffering from obstructive lung diseases, as we have discussed earlier, the patient is suffering from getting air out of the lungs, then the patient would have a very low FEV1, as we have explained earlier and we have demonstrated in this green graph. So what I've written here is FEV1 decreases for both obstructive and restrictive lung diseases, but even more in the obstructive lung diseases, because the patient is having an issue with exhaling out the air, basically. Now, if I go towards the FVC graphs, then I can very easily negotiate and very easily contemplate this graph, that when a normal person has an FVC of this, and the person that is who is suffering from restrictive lung diseases would have this graph, would have a lesser FVC, but with an obstructive lung disease would have the least FVC. Now, if you look at this graph, now this shows the normal lungs, and this is the value of the FEV1. All right, now this was the value in FEV1 in the patient in the other graph, and this is the forced vital capacity. The forced vital capacity decreases in the restrictive diseases, but are the least in the patient with the obstructive lung diseases. I think we can very easily explain this in the context of the earlier explanations. Now, what kind of questions can appear in the step 1 exam and in the boards exams and the various university exams is that you would get the history of a patient with deep shallow breaths, suffering with chronic bronchitis. The patient was a smoker since early teenage, and you would get these kind of statements in your questions, and then some data would be there for you to contemplate. When I talk about step 1 exam, I am strictly talking about the physiology portion of it and the physiology context of this obstructive and restrictive lung diseases. Now, what happens that when a patient with obstructive lung diseases appears in the questions, the patient would have a FEV1 by FVC ratio less than 0.80, or in some books it's 0.70. And when a patient of restrictive lung diseases appears in front of you in your question, if I may say, then the FEV1 by FVC ratio is either normal or increased. So why is that? Because we've seen here that FEV1 decreases for restrictive lung diseases, as we've seen here in the restrictive lung diseases, but more in the obstructive lung diseases. So the numerator is decreased in a very larger proportion as compared to restrictive lung diseases, whereas the FVC decreases kind of closer to in both restrictive and obstructive lung diseases. So the numerator is decreased more in obstructive lung diseases, so this ratio is decreased, and the numerator is decreased less, it's either normal or it's even increased in some cases. So this was all about the obstructive and restrictive lung diseases. So I've tried my level best to explain every single concept in a very simple manner in my discussion. If anybody has a question or anybody wants to learn something else or have a suggestion about this discussion, please mention in your comments, and please subscribe to the channel to get more informative and videos and more content about the step 1 and university exams. Thank you.